today, guys.
Thank you, Grace. And I'd like to thank the Congenital Heart Academy for really giving the whole world a chance to learn and enjoy learning from world eminent speakers in different subjects. So since in the fetal webinars, this is our 6th webinar, we have a lot of viewers on the YouTube, going more than 2K for each of the 5 webinars. We are so grateful to our audience. And today we are going to have a peek on the Italian way of counseling and diagnosing congenital heart disease in the fetal life. We had a previous webinar on Brazil. We might have different countries. The idea is to just share the knowledge and the experience because we have different races and different genetics all over the world. Please allow me to introduce our first speaker. It's going to be about counseling, and this is Professor Maria Rosso. Maria is an associate professor at the University of Campania, and since January 2003, she's the head of Department of Pediatric Cardiology in Monalidi Hospital, Naples. In 2005, she took the degree of Systemic Relationship Counseling, and in 2012, she took the specialization in Systemic Relation Psychotherapy at University La Spezia, Rome, Italy. She had more than 350 publications in international journals, and of course, a speaker in many international webinars. We're so proud to have Professor Rosso to talk about counseling. And I, as a pediatric and fetal cardiologist, especially in the fetal, counseling is very important. And who's doing the counseling and what are we saying in counseling? Is the genetic counselor, is the fetal cardiologist, is the surgeon, is the neonatologist? And we have to share or not share. I think Professor Rosso is going to teach us about that. Welcome. 25 minutes talk and 5 minutes for questions at the end of the talk. Thank you so much.
Hi. Hello, everybody. Do you hear me and do you see me?
Yes, very well.
Okay. Okay.
Professor Rosso, make it like a presentation. Yeah.
Yes.
Thank you.
Okay. Thank you, everybody, a lot for the kind invitation. And fetal cardiology started in 1980 with development of advanced ultrasound technology enhanced accurate prenatal diagnosis. It has come a long way since then, and fetal echocardiography might influence the prognosis, having an important impact on pregnancy and childbirth management, voluntary termination of pregnancy, and CHD in utero early treatment. There is a double phase of prenatal diagnosis. On one side, the improvement of the short-term prognosis and fetal intervention. On the other side, the voluntary termination of pregnancy. The actual curve of survival shows a slightly worse survival for neonates with the prenatal diagnosis. This is obviously due to the composition of the population. More severe CHD are more prenatally detected. But when we analyze the outcome of transposition or duct-dependent heart disease, we see that fetal diagnosis improves the morbidity of newborns with this type of malformation. And speaking about improvement in the short-term outcome, a promising way to effectively influence the outcome of selected patients after prenatal diagnosis is represented by percutaneous fetal procedures, such as fetal aortic or pulmonary valvuloplasty. Fetal cardiac interventions have gained acceptance in the fetal medicine as their efficacy and safety have been demonstrated through the world. During the counseling for fetal intervention, the couple have to decide whether to refer the mother and fetus to an intervention that is not without risks, but that could improve the natural history of the critical heart disease. And given the complexity, the maternal and fetal risks, and the long-lasting effects of the fetal interventions, particular care must be paid to the practice of the informed consent. Prenatal diagnosis poses the dilemma whether terminate the pregnancy or not. And given the increasing of termination, it has definitely influenced also the incidence and prevalence of CHD in the newborns. Voluntary termination of pregnancy caused a huge reduction in infants with complex congenital heart disease, and the option to terminate the pregnancy is significantly influenced by the presence of extracardiac or chromosomal abnormality, and also by the complexity of the congenital heart disease. The pathological event breaks the net change of causes and effects in which we blame our existence. The prognosis expected by the doctor is not necessarily the sum expected by the patients. The future estimated by the doctor consists in the statistical probability of the disease development, progression, and outcome. And if we have a look to the statistical, we see that in 2000, the adult population with CHD has surpassed the pediatric population. But what about the quality of life of the Gucci population? Family was the most important domain reported by subjects with congenital heart disease, and the type of heart defect does not impact individual quality of life. And now let's focusing on counseling in fetal cardiology. During the first year, we have administered questionnaires in 90 pregnant women with fetal diagnosis of CHD and 90 pregnant women with healthy fetus. And it was really surprising, the evidence of no significant differences between mother with or without CHD fetuses. And the anxiety level in the CHD group was lower at the second counseling as in the group of mothers who decide to terminate the pregnancy. It is well known that there are several lights and shadows of the fetal counseling, as for example, the report no cardiac defect, the counseling already performed in another center, the internet consultation, the possible progression of some cardiac diseases, the difficult forecast of the quality of life. We know that the foramen ovale and the ductus arteriosus will close spontaneously after birth, but we can't be totally sure. We know that for some congenital heart disease, like for example coarctation, the sensitivity or the specificity is still low. And if we look at the counseling, the prenatal importance ranking is different in this paper for parents than cardiologists. And as you can see, there is a statistically significant difference in the factor that cardiologists and parents believe to be important in order to continue or terminate the pregnancy. And some mothers preferred to receive more complete information, while others preferred to avoid it, since it would increase their level of anxiety. And rare has been interpreted as a disease with an incidence lower than a case on millions of births, or as few or no one with the same defect. And more parents reported feeling very pressured to terminate the pregnancy by the perinatologist than by the pediatric cardiology. And what about the use of the word? Searching for a common harmonized language. For example, as George Sandor wrote in 1996, if we say 3% of surgical mortality or 97% of survival, it's the same, but it's not the same. If we say the baby has an interventricular defect, it is a hole in the heart, or it is a communication between the two cardiac chambers named ventricle, is the same, but it is not the same. And the intrinsic prosodic component of the language has an important unconscious influence. The reliability of the facts depends on who makes it. In the counseling and psychotherapy school where I studied, they divide the personality in 3 different styles. This is a simplification, but it could be useful for the counseling with parents. The impulsive personality thinks instantaneously in a practical, fast way, while acting in a spontaneous, impulsive way. Parents with this kind of the personality could ask us, how many times will be operated the baby? What is the mortality rate? Will he grow up normally? Will he or she be able to practice sport? Are there any limits? Will she be able to be pregnant? Will he or she need to take drugs, and if yes, for how long? How many times will he or she has to go to the hospital? Parents with the emotional personality thinks and acts driven by emotions, by feelings, by the emotional personality, thinks and act driven by emotion. And so they need times. They could ask us, I am sorry, I don't understand, just a minute. The cognitive personality thinks thoughtfully, analytically, and rationally, and acts in a slowly and precise way. This is the kind of parents that could ask us, can I see a scheme of the cardiac malformation? During pregnancy, there is a tendency to idealization of the newborn with projection and desired quality, feelings, and abilities. The baby occupies already an ideally fantastic space. The birth of a malformed baby represents a mourning, the loss of the dreamed, imaginated song. And prognosis represents the most remarkable central moment in the communication, and it not consists in just a simple information data administration. We need to guide the couple through difficult choice without prevarication. This competence represents one of the most important abilities of the medical profession, as well as diagnosis and therapeutic skills. And many complaints don't happen for missing or wrong diagnosis or therapies, but for missing or wrong communication. Emotion expression is mostly non-verbal. Prosody consists in the modulation of volume, tone of voice, emphasis, and it is less controllable compared to the real verbal communication. It is difficult, the correct distance between us and the patients. Learn to recognize and accept their own emotions is indispensable to avoid to refuse emotions of the patients by ignoring or minimizing them. The risk is to don't feel the others by taking care of the diseases and not of the human beings. From the other hand, adoption of behaviors defined of functional type, characterized by excessive confidence, trying to find in the patient a support to their own fragility. There are 2 possible approaches to dealing with the question of whether the fetus should be regarded as a patient. The first approach is that the physician comes to his own moral decision about whether the fetus should be regarded as a patient. This approach would require the physician to have a clear and sound moral or philosophical basis on which to make this decision. As this author wrote in this beautiful paper, they said, we suggest that the second approach suggested above is preferable, namely for the physician to leave it to the pregnant woman and the partner to decide if the fetus is to be regarded as a patient or not, providing that local laws permit abortion. Adopting that view does not mean that the physician should not have a personal position on the status of the fetus, only that he or she should not attempt to impose it on his or her patients. And if the vision of the pregnant woman in regards to termination of pregnancy or intrauterine therapy for a fetus are significantly odd with the physician moral view, the physician should exercise the right to consensus objection. and hand over the care of the patient to another doctor. During the counseling, assuming a neutral tone of the part of the clinician, not overly pessimistic or optimistic, is vital, but may be extremely difficult to achieve. The ultimate aim is to allow the expectant parents to form their own assessment of the impact the condition would have on their future child. It is the mother perception of the fetal cardiac anomaly and not the cardiologist that should determine the outcome, continuation or termination. It is open to question through how achievable this is in a setting of acute emotional distress where the mother is in a state of shock and grieving the loss of a sought after normal infant. The technological development has not been always associated with an adequate preparation and training of the medical staff on the best counseling performance practices. This issue is particularly challenging in fetal diagnosis, given its great impact on the decision of voluntary interruption of pregnancy and perception of a severe disease. As Jean-Claude Furon wrote in 2000, we cannot run the fetal echocardiography ignoring the consequences of our acts. And counseling is not a dialogue, it's a profession that through relationship between customer and professional aims to facilitate change progress and improve quality of life, enhancing both resources and relationship with the surrounding environment. And in conclusion, we need more counseling skills, university courses during medical school and training. We need to counsel and follow up counseling personalized for each couple. We need a constant relationship with the reference gynecologist of the pregnant women. We need relationship with all the multidisciplinary team, gynecologist, us, surgeon, genetist, nurse, psychologist, neonatologist. And finally, we have to remember that the most important vision is the couple vision. Thank you for your attention.
Thank you so much for such a beautiful talk and really unique in the sense that what is the meaning of counseling? But just if we could go back to the, I think everybody will be interested in the abortion map. If you could kindly just explain a little bit more on that one. There's a lot of orange there and green and stuff like that.
No. Just eccola. You want to see this?
Yes, if you could just tell us about the key to the map and kindly explain to us, because this is very important in counseling. It depends on the legal laws of abortions in the area where everyone is practicing.
There is a big difference, as we can see, between the north and the south of the world, because there are less restriction in the United States, in Italy for sure, in Europe, and in United States and Canada, and it is very different in the other part of the world. So also in Europe, I think there is a difference, because in Italy, for example, the term is the 24 week of gestation for the legal abortion. And I am not sure, but I know that in other countries of Europe, there are no restriction. The term is not the 24 week.
Actually, Giovannella, if I may, in some units like ours with a very strong neonatal intensive care, they have set themselves in Lombardy, the limit is 22 weeks plus 3 days of gestational age at the time of the actual procedure of interruption, at the time of the actual interruption, unfortunately. So that the pressure when they get the patient to 21 weeks, which is usually the time where they've done their morphology scan, as they call it. You have about 5 days to get it together. So because of Europe has different rules, there are families that can be allowed to go elsewhere in the European community, but unfortunately, because the National Health Service in this country does not cover for abortion later than the terms described, which is in the law is very frail and depends a lot on the current standards of neonatal intensive care. We are often against a wall, and some patients, if they choose to go abroad, they have to pay for the procedure, even though within the community it is expected the National Health Service or the receiving country will cover for the procedure for their own citizens. And certainly there are countries where you can terminate the pregnancy as late as beyond the 30th week. But we used to send late terminations to Spain and to Belgium. And now Spain certainly has become Barcelona, which used to be or Nice in France, used to be the destinations of choice for our very complex cases that presented late, started bouncing the cases back because in their nations as well, the limits have changed. If there's anybody else in the audience who comes from those countries, I'd like to know whether they can offer any more insight into that. Certainly, I remember when I went to Argentina many years ago, termination was not available as an option, except for mother's life-saving circumstances, in extreme circumstances, certainly not for fetal causes.
I would say also Ireland will be along those lines as well.
Absolutely.
And also, let me add for the Muslim community, I think 19 weeks is the one where you are allowed by Sharia law to abort. After 19 weeks, it's killing us all. So I think it's between 19 and 24 all over the world. I mean, 22 to 24, North America and Europe, and then the Sharia countries is mostly 19 weeks. But it's a bit complicated in different cultures and different religions. Professor Rosso, who's doing the counseling? This is also very important. We have a big team looking after the fetus. So, and I think from my practice, some patients get very, very contradicting messages from different doctors. Some sort of volunteer to counsel, and many would ask a lot of questions to the cardiologist, to the geneticist, to the obstetrician, to the surgeon. So who's doing the counseling, and how many sessions is a patient allowed to have paid counseling sessions by the government?
First of all, in Italy, they have not to pay. It's a public service. In Naples, in Monaldi Hospital, the counseling is performed by the pediatric cardiologist and the gynecologist together. And if they ask to speak with the surgeon, for example, a transposition, a phallotetralogy, they have a second step with the surgeon. I think that we must be not a lot of people in the counseling, because as you told, if we are a lot of doctors, it is confusing. I think it's better that the first time they speak only with people that is involved in performing fetal echocardiography. So we are two, the pediatric cardiologist and the gynecologist, and that's all.
I think that's very good. And do you do more than one session? Do you think it's more than one session is important for counseling? Because from my experience, I found that the first session is a shocking session and denial, and then you need to come. And I think it's beautiful that you do it as a team. Not in many countries, it's a team thing, but yes, I think a team idea is a beautiful thing. Anyone else would like to add their experience, please?
Simona.
Good afternoon. Yes, we work the same as in Naples. Here in Bergamo, we have a multidisciplinary team with gynecologists and cardiologists. and also a psychologist that supports the families, and an obstetrics that follow the family, the parents during all during the pregnancy about their organization and about the delivery. We usually don't have the surgeon. It's very unusual that we have the surgeon in the counseling. This was a choice of our previous surgeon because he said that it's quite unusual that the surgeon pick the couples the surgical program, because the problem starts before the surgical decision, as Giovannella, as Dottoressa Russo explained. So probably you can interfere too much if you just give the solution and you don't give a general idea of what is the baby, the fetus, and so on. So this is our way of working.
And about the several counseling, I think we need more than one counseling. As you told Rima, the first counseling is always shocking for the couple. So we have to repeat also after 3 days, 2 days, or 1 week, it depends. As I wrote in the conclusion, I think it's personalized. Every couple is different. And so we have to plan the second counseling step by step with every couple.
In Milan, we always do a counseling conjointly with the obstetrician and the clinical psychologist in the first instance. The pediatric cardiology is effectively the one who does talking, but people are there to answer the question if need be. And then we always allow them to have a phone number to hang on to, and or arrange for a second session within a few days, depending on the urgency of the situation. Because of course, if we are on deadline, like 22 weeks plus 1 day, then the geneticist has to come in relatively quickly, and so has the need for the invasive procedure have to be explained, and so on and so forth. But as a rule, that's what we do always as a team, and we're very lucky because I stand on the shoulders of Dr. Feslova, who established that tradition a long time ago, and I inherited her practice and all the good practice in that respect. Certainly, they need more than one session. The first session is barely enough to understand that there is a problem, which is often enormous, shocking, paralyzing, and so I totally agree with Dr. Bader that does require several reiterations of the idea and have them come back. I usually ask the family to write down their questions because in the shock or the emotion of coming back, they very often don't lose the track of their thoughts.
We have two North American fetal cardiologists, Dr. Silverman and Dr. Awad. So, Dr. Silverman, I hope you tell us what is the counseling? Who's doing the counseling in Stanford? From your experience, who's doing the counseling? And is it a combined session with the geneticist and the fetal cardiologist and the obstetrician? Who's doing the counseling, and how many sessions are paid by the insurance?
I'm working at UC San Francisco, not at Stanford anymore.
Oh, I'm sorry.
And the counseling sessions are held first a private session with the family and a nurse practitioner and the doctor explaining the details. We have standard charts of the different lesions, which we talk about. And then the patient is invited to come back if there's any questions, and then the patient is referred to a multidisciplinary meeting with gynecologists, perinatologists, obstetricians, pediatric cardiologists, nurse practitioners for a second analysis.
Thank you so much. Sausan, could you tell us about your experience at Chicago Rush? Are you with us? Okay. She's not with us, or connection is not very good. But come back to Professor Awad. But let me introduce the second speaker, please. And we have Dr. Simona Marcora, and Simona helped me quite a lot in choosing the speakers and the topics. Thank you so much, Simona. And she's a consultant pediatric cardiology in Papa Giovanni Hospital in Bergamo, Italy. She's graduate from University of Milano and served residency in adult cardiology at University of Verona in 2004. So, and then she recently joined the imaging field with MRI, and she's accredited by the EACVI, and she has a lot of publications. Welcome on board, Simona. Thank you.
Thank you for the invitation. It's a pleasure and a great occasion for me to share experience. Unfortunately, we tested my connectivity, so I have to switch off the video during my talk. Sorry for that. Then I will open my face again for the discussion. Okay, just to make the talk faster. Okay, here we are, sorry. So the same trigger that is an obstruction at any level of the left heart can cause important modification in left ventricle signs and function, according obviously to gestational age, severity and type of obstruction, as shown in these three cases. These changes are progressive, as they are a natural fetal attempt to face a new hemodynamic condition. And so they can change during pregnancy, as shown, for example, in this case of aortic stenosis evolving in hypoplastic left syndrome. Therefore, left heart obstruction of fetal heart encompasses a spectrum of lesion from mild to severe. Their management remains a challenge for fetal cardiologists as regard to diagnosis and treatment. Let's start with sharing a case very suggestive for this spectrum. This is a second opinion case who arrived at our institution at 21 weeks of gestation for a ventricular. First aim of this examination is to look for a possible obstruction in left heart as a cause of this right predominance appearance. It's important at the beginning of the exam not only to visualize the heart, but also to measure the heart inside according to standardized view for chamber LVOT view and normalize the number to this score. Our case show a undersized left ventricle, but normally function, as you can see, hypoplastic mitral and aortic valve, but with anterograde flow in the valve, a normal function, as shown here in the Doppler. Then we move outside the heart to study what's happened outside the heart, and with this with trivessel tracheal view and sagittal view, and we can see that there is the arch mostly in this view. We can see that there is this is the cava, this is the hypoplastic ascending aorta and aortic transverse arch with a normal size isthmus, but with a shelf image. So what is the possibility? The possibility is of a possible coarctation as the cause of the disproportion we previously see. So As we said before, coarctation is probably one of the most challenging diagnoses during pregnancy. Ventricular disproportion is the most frequent, found in the screening, is one of the most frequent diagnoses of the clinic. But it's estimated that less than 50% of them will develop coarctation. On the other side, prenatal detection of the coarctation is often low because there is often a big ductus that prevents a correct vision of the arch. So at the end, we can say that the diagnosis of the coarctation is probably a low cost-effective process with a high number of false negative and false positive. That cause often in our practice repeated number of scans during prenatal period that cause long hospitalization after the stressed parent because of. So in literature we have a lot of study in which they try to find some predictors of a possible coarctation after birth. Among these huge sites, most of them are not prospective study with small population, with a bias of inclusion of patients with different gestational age, for example. So there is this meta-analysis that try to overcome this problem of all this bias, looking for at least 12 studies at the end who try to find these criteria. In this meta-analysis, we can see that having as our patient a hypoplastic left aortic arch and a suspicion of a shelf, obviously these are qualitative criteria that the fetal cardiologist gives, are high predictive of a postnatal coarctation. At least 9 cases on 10 patients will probably have coarctation. In addition, this meta-analysis gives us a lot of quantitative parameters that can predict the coarctation. As shown in these tables, studies that match for the same criteria were compared to try to eliminate the heterogeneity of the single studies, and they conclude that fetus with higher probability of postnatal coarctation in comparison to normal fetus have an higher tricuspid valve and pulmonary valve score, smaller mitral valve and the aortic valve score, as shown smaller aortic isthmus, and also high ratio of right ventricle comparison to left ventricle and pulmonary artery in comparison to ascending aorta. A very important ratio is also the ratio between the isthmus and the ductus. Moreover, in this analysis, the authors try to put these predictors together, trying to produce like a score system to try to predict in a more accurate way the diagnosis after birth. If we think we have similar predictor when a baby born with coarctation after birth to decide the pathway for the treatment of these patients. But again, sometimes these scores are time consuming. We don't have often a clear cutoff of this score, and unfortunately, most of them are related to a late gestational age, not an early age. These are some examples, and according, for example, to this score, our population our patients we probably have a coarctation as a cause of the left small ventricle that we see. A disease that we can call, or probably most of us call, hypoplastic left heart complex. Now, what we have to do, the next steps is to try to answer the question, the most important question that the parents ask us. Doctor, what is the problem? How can we treat this problem? Probably the diagnosis of hypoplastic left complex make our counseling very complex, because fetus with this problem can probably be treated at least in 3 different ways, as shown in these slides. And also the problem is that, as we said, things change. The art that we see at 21 weeks it could be a different art at the end of the pregnancy. And so also in counseling, we can predict pathways at 21 weeks when the couple has to decide about eventually a terminator of pregnancy, that will be totally different at the end of pregnancy or at least at birth. So again, look at the literature. We can really have some predictor that help us in answer the question, this will heart be repaired, or this will heart has to go through a univentricular palliation. We don't really have too much articles, uniform articles, I mean, with a uniform population, in this case, a hypoplastic left heart complex, who try to give this answer to us. I found these 3 reviewing the literature. I found these 3 work. Again, you can see different age, and most of the time this score were to study this score population included fetus late in gestational age. Not most of them are retrospective study, and unfortunately most of them, they don't give us also the outcome. I want to explain. They give us, for example, if the fetus has this characteristic, probably you will go to a biventricular palliation, but they don't analyze the outcome of this treatment postnatal. So we don't have a correlation. This is one of these articles, the more recent one. As you can see here, when we see an inversion of the flow at the level of the atrial septum associated to the hypoplastic left ventricle and mitral valve, for these authors, this fetus will probably will be safer after birth with a univentricular palliation with a high level of sensitivity and specificity. This is another study. Again, when we find a higher disproportion between the right ventricle and the left ventricle, and the tricuspid valve and the mitral valve, and the small mitral valve score, these are parameters that can help to predict the pathways. More precisely, for example, having a mitral valve annulus score in the second trimester less than 2 Z-score, and the ratio of tricuspid valve and mitral valve higher than 1.5 is in this study, for example, they say is 100% univentricular palliation after birth. Moreover, is important, as we said before, not only for counseling, also for to describe the patients and to classify the severity of the disease, to follow this art during pregnancy. So we, as usual practice, we For example, we review these patients with the hypoplastic left heart complex at least every 4 weeks, 4-6 weeks, because if we notice an increase of this score or of the ratio, for example, of the ventricle, the pulmonary artery, and the aorta, this means that these arteries do not become bigger, and so this probably it will go to a univentricular. This will happen, as you can see in this slide, also in our patients, where there is at 32 weeks, the heart become very different from the ones at 21 weeks. But unfortunately, there is also an inversion of the flow in the atrial septum that together the inversion in the ductus means a possible univentricular palliation and ductal dependence. These are some videos of the heart after the birth of this baby. I go again to the slides, and as you can see, unfortunately, the left ventricle was present in this patient, but he had a severe diastolic dysfunction. We did also a CAT, and we find a very high level of left ventricle and diastolic pressure. And so at the beginning, we decided for a hybrid to try to follow this art of univentricular palliation with Norvolzano. So summing up, counseling of the spectrum of obstructive left heart disease is very difficult because, for example, we don't have mostly in early stage, we don't have real score, real quantitative parameters that can help to decide. So often I think that our experience, but also I think also the institution surgical preference guide us in the counseling of what will happen after the fetus will be born. Probably, as I show, we start having some scores for late gestational age, but I really think, I don't know, then we can discussion. I really think that in our experience, we use, in this moment, we don't use them a lot. They are probably underused. And probably in the absence of a longitudinal bigger study with same inclusion criteria, with a big population, probably we have to be also cautious in just having all the conclusion with this score. Okay. Then just 2-3 slides before ending about the most severe part of the spectrum. That is obviously hypoplastic left heart syndrome. When you face parents with a fetus with hypoplastic left heart syndromes, counseling becomes probably diagnosis not difficult. You have a 4-chamber without a left heart, and so it's very simple. In fact, it's probably the most very high detection of this disease also from epidemiologic point of view. But the problem is that the prognosis is very severe, and we have a lot of questions about mortality, about quality of life, and probably if we can give some numbers about the future, about mortality, about surgical success of the procedure, it's really difficult to give to the parents scores about what will be the life of this baby. We really think that, and a lot of studies are emerging in the world about studying what is the future from a neurologic point of view, or neurodevelopment point of view of a fetus with hypoplastic left heart syndrome. But again, probably we need more research to have a definitive answer for the parents. The other things is that we are talking about spectrum, and also also inside the spectrum there is another spectrum. I mean, not all the patients with hypoplastic left heart syndrome are the same patients. For example, in these slides, we can see this is a case of hypoplastic heart syndrome with an intact atrial septum. No flow here. This is the septum. There is no flow. Large pulmonary vein, probably some problem in the pulmonary, and this is this condition put the fetus at high risk. And for this fetus, we need before the birth, with all the implication in counseling and that we see before. This is the last case I want to show you. This is the case that we met some weeks ago. This is an hypoplastic left heart syndrome. As you can see here, there is only right ventricle, no left ventricle, associated to a cystic hygroma. This is a 18 weeks gestational age. The couple we discussed the prognosis not only of in this case not only of the heart, but this the prognosis of all the fetus with the parents, and probably the parents refuse about termination of pregnancy, and probably this is the space for not palliative surgery but palliative medical treatment. But unfortunately, here in Italy we don't have stronger programs about this. I don't know the experience around the world. So to come to a term, I think that approaching obstruction of left heart is a very challenging process. If I have to choose 3 words, I would like to choose this one to try to guide and ameliorate this project that are experience. For sure, we have to share our experience, but also we have to be trained. In fact, I think that also to do fetal and to do counseling, every one of us have to be trained into this. We need a lot of research because, as we can see, as we see during my talk, there is a lot of question, but we need probably again a lot of answer with also scientific parameters. But obviously we need also a center with specialized group, with a real team group that works with the parents and with but mostly not with the patients. That is the center of the process. Thanks for the attention.
Thank you so much for beautiful imaging and a very important topic. Simona, just to make it simple, because from our audience, we have different level of people attending this webinar. So you have a live case. How would you know that we suspect coarctation? You put the ratio of the ventricles, you put the mitral to tricuspid. Can you walk us with just a case scenario? How would you do that? Because you put 5 or 6 parameters to suspect aortic coarctation.
Allora, it depends a lot in the period of gestational age, in the scenario. In this case, we were early in the gestational age, so probably when you find a so big disproportion between the dimension of the left part of the heart, probably is very suspicious that there is a problem in the obstructive problem in the arch. So if the mitral valve is normal, like in this case, no obstruction in the mitral valve. The aortic valve is normal, like in this. Don't find fibrinostosis, that is a signal of aortic stenosis. It's quite sure from experience that the problem is in the arches. So this is from an experience and qualitative point of view. For sure, then also there are some ratio. Probably one of the most important is also from the tri-vessel is the dimension of the isthmus and the transverse arch. Usually, if they are very small, at the gestational year, they are quite associated to a coarctation, and also the proportion of this structure with the ductus. When you see that this structure, they are very small in comparison to the ductus, you see in this case the ductus were very enormous, a big ductus. I think it's one of the most real parameters. Then of course you have a lot of parameters. I know that some of us measure also some, for example, the distance between the isthmus and the subclavian, but I think that if you add a lot of parameters, probably you get in confusion, and probably some of them are not difficult to be taken in every scan.
Thank you. Dr. Silverman, I can see that you want to talk.
Hi, well, I enjoyed both of these talks, and I think that these are particularly difficult issues to make a clinical decision on, but putting the two talks together, I think that it's always advisable to express the concern and doubt in your own mind to the patients in terms of counseling. I've discussed this with Dr. Wayne Turetsky, and as far as the coarctation, he says, it's a win-win situation when you tell the patient, and we usually have those patients deliver in our hospital so that we can access them for immediate postnatal assessment, which is still, I think, clearer and better than the fetal counseling. And so if there is a coarctation, then you've had the patient in the hospital and you can treat them. And if not, well, then the patient wins because they don't have to need an operation. And I think the same is true of the borderline left ventricle. I think that it's always a doubt, and the best thing to do in doubt is to bring the patients to deliver in your institution if possible, and then go from there in terms of the postnatal diagnosis. I don't know how Simona feels about that, but perhaps she could make some comment.
Yes, we have the same protocol. Usually, it depends also on the level of suspicion. If the level of suspicion is not high, usually we ask the parents if they live not far from the hospital to arrive without a planned vaginal delivery, just to alarm the groups that in a moment of the prenatal diagnosis, we have a suspicion of coarctation, and so at the birth, the cardiologist arrive to confirm or not confirm the diagnosis. Instead, if we have a high suspicion, in this case, I think that it's very interesting to try to have score, just to not to treat the patient in the same way from a planning view. If you have a high suspicion, that we are quite sure that we have to start prostaglandin at birth and so on. So we usually admit the patients, the mother, not the patient, the mother at 38 in our hospital. The mother usually stays some day, wait for a planned vaginal, and usually the neonatologist start the prostaglandin. And then for sure we have to follow some days with art. Usually we do a test, we try to stop in not so clear case, to stop the prostaglandin, and we see what's happened when ductus is closing. I agree with you. This is a long process, probably a stressful process for the mother, because sometimes you take some days just to say, oh, we were right, there is a coarctation, or we were not right, there was anything, the heart is normal. So I think it's a real tough part of our work.
I think, Dr. Silverman, I think it's we have to make it clear. We are talking about discrete coarctation without hypoplasia of the arch. Is this correct?
Yes.
So this is where it's difficult to diagnose, and this is where it's okay to make mistakes. But when we talk about hypoplasia of the arch, it's much easier. Now, the criteria that Simona put in the ratio of the ventricles, the ratio of the valves, and the ratio of the ductus to the isthmus. What do you think, Doctor, from your vast experience, which ones are really the ones that you would, with your experienced eye, say, oh, there is a strong chance of coarctation? And I want to say that great people with coarctation many times are not very confident. Is this true?
Yeah, I think in our institution, we've just published a paper about the relationship of the size of the isthmus. And I think that certainly when the isthmus is small, even Dr. Lindsay Allen had said if it's smaller than 3 millimeters in the late term fetus, you should beware of the possibility of coarctation. We also use the ductus isthmus ratio. There are many causes of disproportion as well, and so that if you rely just on that, you find you're going to be in trouble in many situations. So I think that numbers are great, and numbers usually help you best when the situation is clearer. It's the problem is in the middle of the situation where there's doubt about the numbers being correct, that you have the problem where most of the important issues about making a differential are important. So, you know, let's say a 3.5 millimeter isthmus, just as I've used that measurement, it could be a coarc, it could not be a coarc, for example. And under those circumstances, I think you have to look at the situation postnatally. And even the caution about postnatal coarctation is because ductus tissue constriction is important in terms of making the diagnosis. And of course, the ductus is usually open in utero to make this decision, that as the ductus tissue constricts postnatally, coarctation can develop not immediately at birth, but several months after birth. And I've had certainly this kind of experience where everything looks pretty clear in utero, and then at 3 months of age, the patient starts to have evaluation and coarctation is discovered. So there are always these outliers that you have to be careful about.
And not just that, because there are also seen cases where you have ventricular discrepancy, and at birth everything was fine, and later on they developed discrete coarctation. So
Correct.
There was nothing. So this is also a very tricky. Also, we have to say, I think you would agree that the presence of the shelf is not in utero an important thing like we do postnatal.
Sure.
Absolutely.
The case that I described happened to be in one of my colleagues who's a pediatric cardiologist in Philadelphia now. And it was his own child who we did a fetal echocardiogram on, and the baby was normal at birth with normal pulses, etc. And at 3 months, a coarctation and double orifice mitral valve was discovered. And I think that to speak to Simona's point there, I think that when you find a patient perhaps with a bicuspid aortic valve or with mitral valve abnormalities or other concerns, is that perhaps this warrants long-term postnatal evaluation and not just simply say, well, at birth, things look very normal.
Thank you so much. Anna, you want to comment?
Well, thank you. I think I totally agree with the fact that coarctation is tricky. And my own junior colleague has had a very nasty experience, herself a very experienced pediatric cardiologist, of detecting coarctation in her own child who had perfectly normal prenatal cardiac ultrasound, not just done by myself, but also done by one of the top fetal echocardiographers in Paris to have a perfectly normal looking isthmus and perfectly proportioned ventricles and all the rest of it, and a normal aortic valve, luckily. And then at 10 days of age, it developed one of those coarctation that was kept for a few days in observation, because some days it looked tighter, some days it looked smaller. And it's often our experience. We certainly have erred on the side of exceeding in caution in having these mothers deliver at our institution when the doubt was strong, either because of the look of the shelf or the funny looking isthmus, and certainly a small transverse arch. The measurements and the scores are important, but sometimes it's a look of the aspect, the visual aspect of the arch that puts us in suspicion. And sometimes we've created unnecessary anxiety, and we apologize for it. But with our institute, the hospitals, peripheral hospitals that gravitate around our institution are not comfortable in delivering babies in which a systemic obstruction has been hypothesized, however weakly. So, and definitely, if a doubt has been raised in pregnancy, it is a must to follow the child well beyond the neonatal period and check it from time to time.
Thank you so
Sure,
much.
and I think that just to follow on a counterpoint to Anna Colley's remarks, I've been associated with a patient on a medical legal basis who was diagnosed in utero with a probable coarctation, and at birth the patient was found to be normal and was told to come back at 10 days of age, because that's usually the time that the patients get sick. And the pointed caution over here is that at 5 days of age, this baby who'd been discharged from the hospital started to develop signs of congestive failure, which the mother obviously didn't recognize. And then she took the child back on a railroad train back to the city to be seen by the patient. And by the time the baby arrived in the hospital, the baby had passed away. So I think that the caution is, you've got to, when you think of coarctation, it's a dangerous disease and it can present relatively early, much earlier than the 10 days as usually described in textbooks. So
Do you
I
agree?
think that's another point of caution.
This is very serious medical legal aspects, but do you agree that some of the little hints is that if you say that the isthmus is equal to the size of the left common carotid, so if it's smaller than the left common carotid, it's abnormal, the isthmus? Some people, instead of doing this, Dr. Silverman, you muted yourself.
I have. I'm sorry. Well, I agree with you. I mean, this is again what somebody once called the tyranny of numbers, you know, because I think that numbers can let you down. They can help you. And I think that, you know, I'm not sure whether machine learning and deep learning and that sort of issue with computerized assistance will help us make better diagnoses. But I think that relying on one particular number is always a concern.
There is a question here for the panel from Putri. He says, or she says, I have a patient with small transverse aorta with reversal flow at 3 vessels view and also aortic arch view. Postnatal echo revealed no co-arc. Can you kindly explain the reversal flow at 3 vessels view? Bit tricky, yeah?
Pretty tricky.
So the patient has a reversal flow at 3 vessels view and aortic arch, but postnatally is no coarctation. Now, my comment will be, how was your Nyquist limit? Because if your Nyquist limit was very low, you can have anything seeing it at reversal. And Dr. Silverman, I think it's also important to see how we're cutting the 3 vessels and the arch, right?
Yes.
So any other physiological explanation to that?
Well, I think, yes, the explanation is that, of course, that perhaps there was some narrowing, but also if you don't cut right in the middle of the arch, the arch can look hyperplastic. And so you've got to be very careful about how you do the scans. And again, I think that doing a long axis view of the arch as well as a 3-vessel view is very helpful. And if it's abnormal in one and not in the other, that probably you've not cut it in the right place.
Well, yeah, but they're saying it's abnormal in both, in the rear vessels and the transverse. So we have to move now. I'm sorry, I'd like to introduce the third speaker. And Anna, I mean, reading the bio, she's been all over, and she's actually doing fetal cardiology, pediatric cardiology, congenital adults, and so on. And Anna has been to working with Jane Somerville, a very interesting professor of congenital of grown-up congenital heart disease, and also she's been to Boston, working with the Boston group in pediatric and fetal cardiology, and now she's offered a position in Milan Main University Hospital, and she will be she's doing invasive, non-invasive, interventional, fetal, other congenital, and of course running a very busy clinic, being one of the fellows of Jane Somerville. And we're very happy to have you, and thank you so much for accepting the invitation.
Well, I think I'm much less than you said. And in fact, the thing is, I came to fetal medicine much late. I started out in traditional pediatric cardiology and Gooch medicine with Jane and the Great Ormond Street group. And it was only ever since I moved to the University of Milan main site, which is a big maternity hospital counting about 7,000 deliveries a year, most of which pathological because they're selected by pathology, that I've actually had to learn and become a fetal doctor. But I kept a hand in the Gooch section because I'm actually coordinating the care of grown-up women with congenital heart disease. But fetal takes up about 30% of my time. And I appreciate everything I've learned from all the giants on whose shoulders I'm standing on. So, well, thank you for deeming me worthy of being here. I hope I won't disappoint you, but certainly I don't have any commercial disclosures, never have. I'm very grateful to a number of people. One of the giants whose shoulders I'm standing on is Dr. Silverman, who I've known for a long time, although I've never actually had the luck to work with him, and some of my associates right now. And of course, being in a university position, have the trainees help us, make us better clinicians. I do owe you an apology, as some of my MP4 files will not be included in the presentation, and I will show them to you at the end, getting out of the presentation. I've been given the remit to deal with Conotruncal abnormalities and the differential diagnosis. So I've kept a completely clinical profile to this, what looks like. And I think of the Conotruncal abnormalities, we need to know about the fetal heart, everything we need to know about the postnatal heart, in as much as we can obtain it, and bearing in mind that in the fetus, the situation evolves, and therefore the Polaroid photograph that we get at 18 weeks or 20 weeks is going to develop into progressing lesions, especially systemic and subpulmonary obstructions. AV valve regurgitations will deteriorate, and signs of heart failure might occur later in pregnancy. And so making the diagnosis doesn't stop our job, and requires that we follow the patient through. Also, this brings to my mind a word of caution to the enthusiasm the obstetricians often manifest in the face of a potential diagnosis of congenital heart disease at early prenatal screening, as early as 10 to 12 weeks. And although microTAC assessment of products of terminations of pregnancies at this time have shown a fair accuracy of the diagnosis, I still think that in these instances, I'd be loath to counsel a couple to a final destination of the fetus as early as that. And I think I would require a somewhat longer follow-up of the patient in some of the clinic. Although I do realize that terminating a pregnancy, if that's the view of the couple at 12 weeks, is much less traumatic than doing so at the second trimester, which is when we often are faced with the decision. Of all the details that we need to know, the most important ones are certainly the relationship of the great arteries to each other and to a VSD if present. And in conotruncal abnormalities, the VSD is more or less the rule. We need to know what the conal septum is up to, which tricks is preparing to play, whether it's going to produce a systemic tract obstruction, which has been already dealt with in other settings, or in and so we have to check for coarctation evolving and for coexistent interrupted aortic arch, whether or not the arteries are proportioned or disproportionate. It also points to the degree of obstruction we'll be expecting after life. And of course, we'll need to check for what are the sources of pulmonary blood flow, because sometimes they may not be the antegrade RV to PA connection, but they may come from other sources that we need to know about. And of course, in conotruncal abnormalities, it's an absolute imperative to know more about the fetus, because the association with extracardiac anomalies, both in the setting of genetic abnormalities involving an abnormal karyotype or minor or different genetic setting such as 22q11 deletion, but also syndromic setups which have not as yet got an identity, a genetic identity card univocal and established, such as the association like charged bacteria and so on, are very common. It's a mostly represented group of abnormalities, and therefore this is one of the fields where the obstetrician and the cardiac specialist are welcome to work together. We run a combined clinic, as a matter of fact, all the time. One of the things that may strike your image looking at a child and makes you think of a conotruncal abnormality is when you see two ventricles and a vessel somewhere in the middle with something that looks like a VSD at the bottom of it. And that certainly is confirmed by a better viewing with a different position, with an overriding aorta, which now overrides two ventricles, which are reasonably well balanced between each other. The pulmonary outflow is not so well visualized from here, but can be guessed at the back. And certainly we need to check for that in different views and go and look for it and size it, check that the pulmonary artery is in fact confluent and that more than expectedly the pulmonary vessels are small. But then we can find a very similar look with the vessel that seems to be single and a single outflow overriding a VSD. And we got a nice, and it's no doubt looking at the supra aortic vessels that we're dealing with an aortic arch. But then we don't seem to be able to identify a pulmonary artery, although we see something small back there that may or may not be. And then we call into the field our guns with we call the cavalry of the color Doppler helping us, and we go and discover that there is indeed there is a pulmonary artery or something that looks like one that gets filled retrogradely from a ductus arteriosus, and that's even better visualized in this image. And we can see here this tiny pulmonary artery that we sort of guessed here. With a bifurcating artery, and this is what may be called an extreme form of phallus tetralogy with valvar pulmonary atresia, duct dependent of the more benign, if I may be allowed to say so, variety. But then we can come across a very similar anatomy with the VSD overridden by an aorta, by by all intents and purposes looks like an aorta, and then we see a big, huge lump of something there, and the cavalry of the color Doppler will tell us that there is a to and fro. The vessels are indeed enormous, and there is a to and fro flow there, and so what we're looking at is a variety of phallus tetralogy with the absent pulmonary valve syndrome, which is even better visualized here. And at this point, the teamwork becomes paramount, because the vast majority, if not the total population with this disease, will have an abnormal genetic setting. This is the Doppler signal that we are used to see in this patient with the to and fro flow from the pulmonary valve, which is not there. And then this may look something very similar. Again, we got an overriding aorta, but we see nothing that looks like a pulmonary artery. Probably the infundibular, which I'm sorry I cannot show you here, is not particularly visible or indeed permeable. And we again call the cavalry in with a color Doppler, and we see various peculiar vessels spreading themselves on the lungs. And this is probably, in my view, along with hyperplastic left heart, one of the diseases that makes me cringe more, although I think we all owe Frank Hanley a huge debt of gratitude for having improved so much the outcome of this patient with his magic surgical tricks. And there is one thing in which I do not resemble my professional mother Jane, in that I'm not so much of an enemy of surgeons as she is, or she's perceived to be. But then again, going again on a single outflow, which is again a situation which is not uncommon in conotruncal diseases, we may be wondering where the pulmonary artery is. Of course, the ventricles look relatively well balanced, and there is an overriding vessels. And if we look carefully while the film develops, we got a nice aortic arch, and then we can see a second vessel being delivered from here. The valve that delimits this common trunk is not well seen here, but we see in this other example, not so different in anatomy, that the valve is somewhat thickened. And when I'll show you the pictures at the end of the presentation, the MP4s that I cannot put in the presentation at the moment, you'll see that that funny look, even when you don't see the pulmonary artery trunk. And that's how you differentiate mostly a common trunk from an aorta overriding in the setting of pulmonary atresia VSD, where the aortic valve is usually normal and continent. Oops. Okay. And then the outflow can show us some other surprises. The most common and of which is the parallel vessels. Parallel vessels do turn out in the setting of simple transposition, in which we are obliged to look for whether or not, besides having a transposition of the great arteries, two vessels parallel the aorta anterior, pulmonary artery bifurcating posteriorly, as seen here a little bit better. Here we can see the innominate artery bifurcating, and here is a pulmonary artery behind, coming from the two ventricles. Sometimes we are not so easy in visualizing the bifurcation. This case, it wasn't so clear, but it was made clear once we got color Doppler to come to the rescue, and the bifurcation in the setting of complete transposition, intact septum. There is no shunt across the ventricular septum. And in this disease, the diagnosis is fairly simple and straightforward, and right now quite easy to detect prenatally. I'm not sure what the situation is in other countries, but since 2009, obstetricians in Italy have been required by the current guidelines to visualize the outflow tracts and to make sure the two vessels cross each other normally, as opposed to being parallel. And although detection of conotruncal abnormalities still remains somewhat less marked than atrioventricular septal defects or disproportionate ventricles in the setting of a right or left ventricular hypoplasia, detection rate for conotruncal abnormalities improved to an acceptable level. Transposition is, however, still a surprise. We had an unexpected one a few days ago, which had also a restrictive ASD, which gave us the heebie-jeebies, and we had a really hard time and got to theater just in time. But then not every time we see parallel arteries, we are in the setting of simple transposition. we need to make sure the arteries come out of separate ventricles. And in this case, we are highly suspicious that they may not be it. May not be it because there are two vessels and they're very displaced anteriorly compared to this is the anterior part of the chest wall. And they appear to be very displaced anteriorly. And we can see the larger vessel is probably an aorta, and the smaller vessel may be a pulmonary artery. We need to see the bifurcation better. In this case, we are definitely sure that most of the arteries come out of the right ventricle. This is the anterior wall of the baby. And almost 50% of the overriding vessel is over to the right. There is a tiny touch of conal septum. We cannot comment here on whether there is mitral-aortic discontinuity, mitral-semilunar discontinuity or not, but that would also add an additional sign of it being a double artery right ventricle by all means. I personally would have no doubts in judging that. This woman who was a diabetic with a not particularly easy abdomen gave us some trouble in trying and figuring out what was really going on. We could tell the vessels were parallel, but it took us quite a long time to figure out that they were actually both coming mostly from the right ventricle, although at this early age is still not quite so clear. One of the hints could be that if you watch it carefully, there seems to be a little bit of muscle separating the anterior mitral valve leaflet from the semilunar valve. We still don't know what it is. We can kind of guess it may be a pulmonary artery, but we're not totally certain. There is certainly a conal septum there, and there is an anterior vessel, which will then be declared by using the sagittals views, which the obstetricians use for the spine and we use for the aortic arch, to identify the anterior vessel as the aorta with the supraaortic trunks and the posterior vessel as a pulmonary artery, which we has difficulty in identifying. Otherwise, here the bifurcation is not at all clear, and that is an everyday, it is a real life situation that we often have to fight with. And again, this is a case that floated into clinic Tuesday morning, and we see two parallel vessels, and we say, fine, it's a transposition, but where do these vessels come from and which is which? And we get a little bit of time to get the posterior vessel is the pulmonary artery, huge, and the smaller vessel is therefore an aorta. And we then, from the forechamber, which of course we'd seen before, we see that there is some disproportion of the arteries. The left atrium with the pulmonary veins drains, in fact, in a ventricle which has a septophilic valve, to quote Jim Locke, and a slightly more apically displaced AV valve, and a moderator band at the apex of this ventricle. And so we're looking at atrioventricular discordance. Here we have a right atrium, which looks into a valve which you don't see very well, but there are no chorda to the ventricle. And I will show you the videos later as well, because we have this technical problem that I mentioned before. And so we are looking at parallel vessels coming out of AV discordance. Are they simple congenitally corrected transposition or not? I can anticipate to you the answer. It's not. It's a systemic double outer right ventricle that we will be looking at in a moment. And congenitally corrected transposition, I'm sorry, this video is rather small. It can be easily identified looking at the forechamber and the outflows, but the hint may come from seeing the arteries depending on which sequence you're obtaining your images from. So the take-home messages that I would give to the less experienced people in the audience and the trainees and the sonographers is that differential diagnosis can be tricky. It's particularly tricky in double outer right ventricle. It depends on the equipment, which not always is the latest issue in ultrasound machinery. Can depend a lot on the woman's characteristic of the abdominal wall and ultrasound sensitivity. The fetal position is a major issue, and all of us have been known to fight for hours to get a fetus to turn. I'm personally not very brave. My obstetrical colleagues are much braver at giving fetuses pushes in order to get them to turn around. We, in our more home-like practice, have found that if we have available something very sugary to give to the mother, it often helps in changing position very quickly. So our outpatient clinic, our fetal clinic, is equipped with chocolates and biscuits, which we are not allowed to dip into. And that helps a lot. And of course, one of the things which is not part of the standard obstetric cardiac ultrasound, but must become part of certainly the cardiologist standard cardiac ultrasound, is the use of sagittal views, which oftentimes gives you a helping hand, not only in establishing the anatomy of the arch and the ductal arch, which we're very well used to, but also in establishing the VA connection and relationship of vessels to each other. It can be decisive in making the diagnosis. And also, like in postnatal echo, we need to become confident with off-axis views. The obstetricians don't like them because they find it difficult to follow. But especially for complex conotruncal abnormalities, we absolutely have to rely on them. And this is my institution where I hope to be able to have at least some of you as guests at some point or another. And if I may impose on you to show you the cases I showed you before, one of them is the truncus, which hopefully will start relatively quickly. I should mute my video to make it faster. Oh, come on. Well, it looks like it doesn't want to be.
I think you need to make sure you're sharing the right screen on the Zoom.
I will in a minute. I just wanted to get that up. Okay.
You've got to go back on your screen and share a different screen with us. Go start a new share.
Okay. So thank you.
What you want to put up, and then just put it up. Click.
Yep. Oops.
There we go.
Can you see it now?
Yes, we can.
Beautiful. Yes, thank you.
So I was really frustrated not to be able to show it to you before, because it's a very nice example of a type 1 truncus.
Yes. With aortopulmonary septum there.
Yeah, with a nice aortopulmonary septum and an easy surgical approach.
Yes.
Shown here in color. You can see it here. This is a case from Simona, in actual fact, that she was kind enough to give to me. And we should be getting, wait a minute, where are you? I'm sorry, I'm a complete techno disaster. That is something I got from Jane.
Here we go.
Oh dear, here we are. That's when you know I'm over 60. And the aortic arch, of course, is not relevant to the conotruncal abnormality, except to make sure that it's not interrupted, which of course will make the surgeon and the patient none too happy. And the other issue that I'd like to show you, if I may, is this disaster that we saw the other day. Oops. And this is the patient with the parallel vessels, the double artery right ventricle in the setting of congenital corrected transposition. And unfortunately, the smaller vessel is straight and points straight to the head, and this one seems to bifurcate.
You can't see your screen.
Oh dear.
You need to go back and share that screen with us.
Ooh, bugger.
Just go back into Zoom, start a new share, click on the screen when you have it up.
Okay.
It's much better if you include them in a PowerPoint presentation. You don't have to-
I tried, but PowerPoint decided to not want these at the last minute, so it just couldn't work that way. That's what I really would have liked.
That's fine. That's fine. That's very good. I mean,
It's
we
one
can
of those
just-
disasters, one of those last minute disasters that happen when you are in a hurry.
Well, it happens
Right.
many times, so it's fine.
I'm
Well,
sure.
anyway, it was a great talk, Anna. Thank you very much for sharing those cases and the dilemmas with us. The only dilemma I want to talk about is the dilemma that I have, because I've been listening to Bob Anderson and Diane Spicer every Friday morning, and there's been a series of papers and presentations on double outlet and what constitutes double outlet. And we don't believe that you can actually use mitral aortic continuity as a presence of double outlet right ventricle anymore. And I don't know whether this is generally accepted by the Europeans. It's not accepted in the United States, certainly by a large number of people. But whatever the situation is, the reality is that there's a spectrum of lesions in conotruncal abnormalities. On the one hand, you have a tetralogy with a subaortic ventricular septal defect of double outlet right ventricle on the one hand, and this is a spectrum of diseases. On the other hand, you have the disease of transposition with a VSD with a double outlet right ventricle of the Taussig-Bing variety. And these are on a spectrum of abnormalities, and as we understand the development from fetal cardiac morphology, this is just a simple, almost half a day change in development where it is averted. So I don't think it really makes any difference whether you call it double outlet. I like to look at how much of the aorta is overriding the ventricular septum, or the great vessel is overriding the ventricular septum to make that diagnosis. But I think there is no universal agreement on this problem, on the nomenclature, not the patient's disease, but the nomenclature.
But
Sure.
the important thing is that, yes, Dr. Silverman, you're making it very simple. The 50% rule is beautiful. But the idea behind that is how far the VSD is from the whole story, right? So,
Yeah,
absolutely.
also how far, I think I would suggest that people, when they talk about double outlet, also they would also, the surgeons, or when you're presenting, they would also wanted to know how far the VSD is from the great vessel,
Absolutely.
right?
Yeah.
Do you
Well,
agree to that?
absolutely. I think that my friend Leo Lopez on the nomenclature panel will probably kill me, but I have to say that I tend to agree with a more practical approach, tell the surgeon where things are and whether the aorta is easy to connect to the left ventricle or not, and whether he has to enlarge the VSD, or whether the VSD is somewhat relatable to the arteries, whether he can switch the arteries and obtain a good circulation or not.
Well, and you
Dr.
can't
Silverman.
always rely on the surgeons to give you accurate information. I've had that experience with a very experienced surgeon I worked with at Stanford, who had, because of the coronary artery, had to put his incision in the right ventricular outflow tract in a different position, and swore that the patient had double outlet when we had diagnosed a clear tetralogy of Fetal. So I think that you have to be very careful, and this is, I like to think of these all as a spectrum of abnormalities. On the one hand, with double outlet, could be either of the tetralogy type or the Taussig-Bing type, and leave it at that.
What
Okay.
about the double disco and the ventricular inversion? Now, Dr. Silverman, what would you say the hints to this difficult diagnosis antenatally? Is it just ventricular inversion or double disco discordant?
Well, I think that if you look at the morphology of these conditions, and I think your pictures were great, by the way, but I think that most of the time when you see discordance, atrioventricular discordance, the findings are usually of double outlet. I think that's the usual situation, overwhelmingly. So when you find that you've got atrioventricular discordance and two vessels that are coming out close to a interventricular communication, that's probably double outlet.
With atrioventricular discordance, right?
Yes, correct. That's your
What about
question.
just ventricular inversion? This is the rare thing that that you could see
Well,
antenatally.
Yeah, I've seen maybe 4 cases of ventricular inversion in my life, so I can't speak about it in any authority. One of them had no ventricular septal defect. I just came across a paper in the literature the other day with that, described in the fetus, by the way, where they diagnosed a double outlet from this particular right ventricle.
So when we talk about ventricular inversion, what made you say it's ventricular inversion in utero and not?
I think that you then have to approach sequential segmental anatomy, look at the veno-atrial connections, the atrium morphology, and then the connections between the atrium. And as Anna had shown you clearly, the morphologically right atrium connects to a left ventricle, and the morphologically left atrium connects to a right ventricle. That is atrioventricular discordance, and by definition. And I think that we have to apply these rules that we know to the fetus as well.
Thank you so much.
The next question is the ventricular arterial connections. How are they connected? And that's where you get into this issue with, is it transposition or double outlet right ventricle, or what other ventricular arterial connections you have?
Thank you so much.
We've actually concluded for double outlet. And as we speak, the surgeon is counseling the couple with my colleague.
Thank you. We have to move because it's getting late, and our last speaker, but not least, is Dr. Cosimo Marco Campanelli. He's been sitting patiently and quietly, and sorry for this delay.
No problem. I enjoyed so much.
And I think you're the youngest in the whole panel. So he's graduated in 2010 from Rome, and then you went into cardiology fellowship in July 2016, and then you're doing the perinatal cardiology at Bambino Gesù Hospital. In 2015, you went to heart transplant team to Great Ormond Street, and then you went as a research fellow to Boston Children's. Your interest now is in MRI, vascular rings, imaging, and fetal cardiology. And Wes, welcome. And you're going to talk to us about abnormalities of aortic arch, vascular ring diagnosis, and postnatal management. Thank you so much.
Thank you so much for the presentation, and I thank you all the organizers for the invitation. And yes, I'm probably the youngest, but that's why I'm so honored to be here as a speaker after having participated as a listener to these sessions of Congenital Heart Academies. So I will talk about the abnormalities of the aortic arch, focusing on the vascular ring, not to overlap with the Simona, who just talked about the aortic coarctation. And I will focus on the diagnosis and postnatal management. And I will show you our experience here at Bambino Gesù Hospital in Rome. I have no disclosures, and I will touch these topics. I will talk about the dimension of the problem, and then about the fetal diagnosis and the postnatal management. And then I will show you our approach at Bambino Gesù about the management of this kind of patients with this kind of abnormalities. Why are we talking about the vascular rings? Because in our fetal lab in 2020, this has been the second diagnosis in frequency after, as you see, after aortic coarctation and VSD. So it's a problem we need to deal with, and we need to be focused and prepared when we counsel the parents. And just in order to link to the previous talk of Professor Russo, it's one of the topics where the counseling it's a very particular, must be very detailed, because it's one of the situation where the family has the greatest level of anxiety compared to the often benign fashion of and a phenotype of these abnormalities. So we need to understand. We need to know that there has been an increase in diagnosis in the last decade in our hospital, and this has been confirmed by the increase in publications about right aortic arch and vascular ring in the literature up to now. Why is this? I will skip the definition. I think we all know that the vascular ring is a structure, is a vascular structure that encircles the trachea with the possibility of symptoms in the postnatal life. And why there has been an increase in the diagnosis of vascular ring in the last decade? Because the gynecology team gave a big contribution to the diagnosis of this abnormality, not because there has been a change in epidemiology. We don't think so. The gynecologists, they identified two simple signs at the 3-vessel view of a fetal scan to identify if there is an abnormality of the position of the sideness of the aortic arch. The V shape, they associated the V shape to the presence of a left aortic arch and the U shape to a presence of a right or a double aortic arch. But we asked ourselves, is this enough? Do we need? Do we really can rely on this duality, U shape or V shape, to say that there's an abnormal aortic arch or a vascular ring? This is what we try to answer in our work that we published in 2019 in the ultrasound in obstetric and gynecology. And we looked for not only to the position of the aortic arch compared to the trachea, but also to the anatomy of the ductus arteriosus and the anatomy of the epiaortic vessel branching pattern. And then we found that in 5 years, 45 consecutive patients who received the postnatal diagnosis, they had, the vast majority of them, they had a U-shaped appearance. The 7% of them, they had a V-shaped appearance, patients, fetuses with the right aortic arch. And what we found is that the U-shaped appearance, as we know, it's made by the right-sided aortic arch and the left-sided ductus arteriosus. Thus, these two structures, vascular structures, they run in the two different sides of the trachea of the thorax. But the U-shaped appearance means there can be several variants of this. The most frequent variant is the presence of the aberrant left subclavian artery, as we see at this more cephalad scan of the fetus. We look at the artery running towards the left side of the thorax and thus running behind the trachea and behind the esophagus in a right-sided aortic arch with a left-sided ductus arteriosus. And the second form in frequency is the double aortic arch, meaning that there's a right aortic arch and the left-sided ductus arteriosus, with the left-sided left aortic arch usually hypoplastic compared to the right-sided aortic arch. Thus, the double aortic arch for us means a double vascular ring. A vascular ring made by the right aortic arch and the left aortic arch, and the other one made by the right aortic arch and the left-sided posterior ductus arteriosus, so that the surgeon needs to resect the two structures, the left-sided aortic arch and the left-sided ductus arteriosus. The third form, not to be negligible, is the right aortic arch with the left posterior ductus arteriosus and the mirror image branching of the epiaortic vessels. As we see, if we try to follow the first branching vessel running to the left side of the thorax, we see that this vessel bifurcates, and then we can say that it's a nominate artery running to the left of the thorax, and there is no posterior running subclavian artery behind the trachea. And we also found fetuses with right aortic arch and a V-shaped appearance, meaning that the ductus arteriosus was right-sided. So it is also possible to get a V-shaped appearance in the presence of a right aortic arch. And this is usually considered a benign form because it's not associated, it does not form a vascular ring, but sometimes we have seen, and I will show you later, this has been a clinical problem, and this has this has needed surgery. Also these patients need to be followed up during postnatal life. So we thought the tips for fetal diagnosis of a right aortic arch is to establish the reciprocal position of the trachea and the transverse arch and the ductus arteriosus, more than looking for signs of V or U-shaped appearance at the three-vessel view. And then, if possible, if the acoustic window or the gestational age allows, we can look for the aortic vessels anatomy with more cephalad scans of the fetus. And so the take-home messages that we underline in our paper is that V-shape and U-shape is not enough to define the anatomy of the vascular ring, that the V-shape can also be present in a right aortic arch, and U-shape always means that there is a complete vascular ring. So this must be explained in the counseling and the patient must be followed up after birth. To progress in the fetal diagnosis of vascular ring, we are routinely adopting the fetal cardiac MRI to diagnose prenatally the exact anatomy of the vascular ring in order to improve the counseling of these couples. And we are also using the MRI images to create the 3D modeling of all the cardiac diseases, in particular the vascular rings anomalies, in order to help the comprehension of this disease for the family. And we provide families with this nice flyer with a QR code where they can scan and they can be navigating into the online version of the 3D model. So now, how do we approach the patients with a vascular ring in a postnatal life? I would like to focus on the usefulness of the postnatal echocardiography in the diagnosis of vascular ring. We believe that echocardiography is still important for the management, for the assessment of the vascular ring, because I will show you the usefulness during this talk. We try to apply the lesson learned from the CT. We learned a lot from the axial scan of the CT, where we can explore and learn everything about the vascular anatomy of the aortic vessels, of the aorta, of the pulmonary artery, and of ductus arteriosus. And we try to apply this view to our echocardiographic model. So we routinely use this upper mediastinum short axis view to identify the anatomy of the aortic arch and the anatomy of the epiaortic vessels and the ductus arteriosus when it's present. So we can identify, of course, the normal left aortic arch running at the left side of the trachea. Or we can also identify the right aortic arch with all its variants according to the presence of aberrant left subclavian artery or the double aortic arch. So we schematically apply this view, this suprasternal short axis view, and we can also easily identify the presence of an aberrant left subclavian artery in a manner that is comparable to the way that the CT axial plans show us. Seeing if we follow for the left-sided posterior vessel running behind trachea and esophagus, that is a left subclavian artery in a right aortic arch, we can see the same image in a short axis, in a modified short axis view of our transthoracic ultrasound. but we can also identify a complete double aortic arch running around the trachea in the same manner as a CT scan can give us. And we can also identify a double aortic arch in the interruption or atresia of the left posterior segment of the left-sided aortic arch, as the CT scan can do. So in this way, we can delay performing the CT scan in a 1 or 2 or 3 or 4 years old infant. And at the same time, we can confirm the anatomy of the vascular ring variants. And we can also, in this way, in this routinely used nowadays short axis view, we can also identify the most unusual cases, like this one, that is the interruption of the left carotid artery, as you see in this back and forth flow in the position where the left carotid artery should be. Looking very well, we found that this flow was coming from the left posterior, from the left pulmonary artery, meaning, as we confirmed with the CT scan, that the left carotid artery was interrupted and was running from the left pulmonary artery through a closing duct in a right aortic arch with an aberrant left subclavian artery. Let me show you the running CT scan more clearly. If you see the left subclavian artery here and the left carotid artery running from rising from the left pulmonary artery. Even more rare case of an interrupted or isolated left innominate artery. In this case, where we diagnose at echocardiography the interruption of the first vessel, so that the innominate artery was confirmed to be interrupted in the CT scan and was perfused by through the circle of Willis, so from the opposite side of the carotid arteries. So our experience is improved by using this modified short axis views. So now we have a great accuracy in the diagnosis of the vascular anatomy of the vascular ring with the echocardiography compared to CT scan. But we cannot deny that the bronchoscopy and the CT scan are the gold standard for the diagnosis of the vascular ring, but especially for the diagnosis of the impact of the vascular ring on the airways. So where the ultrasound doesn't arrive, then we need CT and bronchoscopy. For example, we cannot diagnose the impact, the dimension, and the entity of the compression by the diverticulum of Comeran onto the trachea and onto the esophagus. We cannot deny the importance of CT and bronchoscopy. This is a beautiful virtual bronchoscopy by CT to diagnose the compression on the airways. Or we cannot deny the importance in diagnosing the stenosis of one of the epiaortic vessels, as in this case, where the left subclavian artery was severely stenotic and the child needed surgery in the first year of life. This is a very particular case, as it was diagnosed as a right aortic arch and the right ductus arteriosus, as you see a V shape and the 3-vessel view at the fetal scan. But then, we classify these patients as a benign form of a right-sided aortic arch, but the patient became symptomatic in the first month of life, and then we needed a CT scan to confirm the presence of a bronchus suis, which was compressed by the presence of the right ductus arteriosus in the right aortic arch. And the patient had an important emphysema of the right upper lobe, and we need to resect the right ductus arteriosus, which compressed the bronchus suis with the right pulmonary artery. So that a multidisciplinary multi-imaging approach is needed in this kind of patients. But also we cannot forget that this patient can also have associated extracardiac anomalies, like this patient who had anal atresia and the left pulmonary artery stenosis. So looking forward, we also try to summarize our experience with patients with right aortic arch in this 10 years of experience, and in terms, especially in terms of prognosis and symptoms and needed of surgery. And we found almost 600 patients in this 10 years followed up in our center for a right aortic arch. And we analyzed the first 200 patients with a median follow-up of 8 years. We found that 1/3 of them is symptomatic, and if symptoms arise, they arise in the first year of life in the vast majority of patients. So that's the most important time where the patients need to be strictly followed up. Surgery was necessary for almost half of the patients, where the vast majority of them were, of course, a double aortic arch, and the prognosis was very good. I will conclude showing our approach, our practical approach at Bambino Gesù with patients with right aortic arch and vascular ring. We follow if we see the patients in fetal life, they can be born in any hospital around the country, but the important thing is that the neonatologists check for respiratory symptoms, which in our experience never have been dramatically severe or at birth. So that's an important information to give parents in order to decrease the level of anxiety, which is raised when someone says that there's a vascular structure around the trachea of his baby. And then we follow the patient around 1 or 2 months of life to diagnose the exact anatomy with a cardiac, with an echocardiogram. And then if the patient is asymptomatic, we follow me up with a pulmonary function test at 3 or 4 months of age. Then we review at 6 months of age. And if it is asymptomatic, we routinely perform a CT scan in around 1 year of life. Of course, if any symptom rises in this period, then we request for an early scan. And according to the compression of the airways at CT, then we request a follow-up, a clinical follow-up, or a bronchoscopy for a second level imaging, a second level diagnosis. And then if bronchoscopy confirms the severity of the compression or the presence of malacia, then we go for surgery, or we go for follow-up if these data are not significant. Then I will conclude leaving you with a question: what do you take, what do you leave after this presentation? And I thank you for the attention.
Thank you so much, Marco. Beautiful talk and beautiful images. I'd like to ask the panelists if they have any questions to Marco.
Sure.
Dr. Silverman.
Yes. First of all, that was a great talk. Enjoyed it. The real issue is now, what is the role of ultrasound in terms of management of these patients on a prenatal basis? Do you get a routine MRI on your patients with suspected vascular rings? That's the first question.
So our experience with the MRI in fetal life is now increasing. It's a recent experience that we are trying to expand, of course, in the more complex anatomies, but we are also trying to apply this routinely to the diagnosis of vascular rings in order to try to avoid the execution of the CT scan after life. Because a big question is, do we really need to scan the patients after with radiations? Do we really need to undergo a CT scan, or we can do MRI before birth and then a bronchoscopy after birth in order to reduce the biological risks? So we are trying to expand our experience in this field.
How many of your patients that you saw prenatally actually had stridor or dysphagia after birth? Have you got a percentage of that you can tell us about? Because I think that's the issue. People can have a double arch or an anomalous vessel and have no particular abnormality from that throughout their lives. What's important is there stridor or is there dysphagia?
Yeah, so we rarely see dysphagia. In about 1/3 of patients, so in a percentage running from 25 to 33% of patients, we observe stridor. But this is, I mean, this percentage include the double aortic arch. So we counsel the parents, the family, and then after birth, we confirm that. Depending on the anatomy of the vascular ring, the prognosis is different. We usually tend to consider the left posterior ductus arteriosus and then aberrant left subclavian artery a benign form, but we do not leave these patients without a follow-up, because we have observed patients completely asymptomatic with a significant compression, with a positive functional test and a compression of 45–50%, and then we followed them up and the compression was increased. Or one patient also experienced dysphagia around 1 year of life. So then we were more confident in sending into surgery after having completed all this process.
Marco, what you nicely demonstrated, because we're running out of time, are you proposing a specific cut to the short axis or the two diagnoses? Because the line of thought is that you diagnose them antenatally with a specific, I mean the echo, you see the U-shaped, and then what is your next step? So what is this new cut that you're proposing? Is it upper short axis?
We are actually just proposing the routine use of this cut. That is a modified cut. It's a suprasternal axial transverse cut, and with a more cephalad scan towards the head. We understand that this cut is not being used routinely in the postnatal echocardiography. So now we are applying this cut routinely in all patients in order to gain experience and in order to identify the exact anatomy, so that we can counsel the parents, we can assess the anatomy, and then we can more confidentially follow the patients up. So I mean,
postnatal, not antenatal.
Yeah, postnatal.
So what is the difference? I mean, what is this upper short axis? What is new in it? What will it show us rather than the usual CT? And because they do cuts anyhow, and you just acquire the image and then you do whatever you want.
It's like a 3-vessel view. I think, exactly. Is that correct, Marco? It's a 3-vessel view postnatally.
Exactly. So
that's it.
Yeah, I mean, postnatally we don't have the ductus arteriosus, so we understand that the diagnosis is much challenging, because in the fetal life we have a ductus arteriosus. But we can also in postnatal life see the position compared to the midline, compared to the trachea of the aortic arch, and then follow the epiaortic vessel and see, and then understand if there's a double aortic arch. Usually there's a big challenge in the differential diagnosis of a double aortic arch with a mirror image branching. And that's clinically a difference, because a double aortic arch needs to go to surgery by default.
So then, newborn, everybody would get ultrasound, echo, echoes, and then CT routine at first week of life, if you diagnose, or only if symptoms are there. Are you going to confirm your diagnosis postnatally with a CT or not?
Well, we do CT at least after 6 months of life, more preferably after around 1 year. in order to reduce the biological risk, but we do echocardiogram to confirm the anatomy. So then, depending also on the symptoms, if any symptom is there, we anticipate the CT scan. Yes, we are more. We are. We know that many centers have different approach, but we are more strict in the follow-up and then in the need of CT scan if any doubt arises.
Thank you so much, Marco. I think we're running
Hang on a
out
minute,
of time.
Rima, I've got
Okay.
some questions.
Okay. Sure.
First of all, I'd like to make a comment about our Italian group today and give them great compliments for their wonderful and thoughtful studies. I think that what Rima has done is to show us the standards around the world is really quite remarkable, and the Italians are well within the norm of that standard. So congratulations to all the speakers for their wonderful presentations. I have just two further questions for Marco. The one is an observation. He started off his talk showing a three-dimensional reconstruction in the fetus, and he showed us no pictures of three-dimensional reconstructions with 3D ultrasound. Is there a reason for that? And the second question is, the anomalous subclavian is a big problem, not a big problem, but an identifier of Down syndrome. Have you had experience with this as part of a vascular ring for anomalous subclavian arteries?
So thank you for the questions. The first question is that, yeah, we are not applying routinely the 3D echo in vascular rings, because we believe in order to have a good 3D echo, you need to have a good 2D images. Once you get a 2D images and you get the diagnosis, you are confident with the diagnosis, then it's enough. The 3D echo could be time consuming and needs a lot of setting, and due to the loss of compliance with the baby, sometimes cannot be very useful. Yeah. And about the second question, Down syndrome, and it's really rare to find patients with Down syndrome and right aortic arch, in my experience.
Just anomalous subclavian.
Sorry?
Just anomalous subclavian in Down syndrome.
Yeah, and we see some Down syndrome patients with the left aortic arch and the right subclavian artery, but we receive a lot of request of fetal echocardiography from gynecologists and in the suspicion of Down syndrome in patients with the right aberrant subclavian, but we tend to reassure the parents that this association is really rare, and the symptoms are really rare, and the form is completely benign. It's not. I tend to say this is not a pathology. This is just a human variant.
Dr. Silverman, there are questions for you. I mean, what you said is beautiful about there's a question about the need for urgent cardiac surgery. So you just said that not every vascular ring will need to go to surgery postnatally, depending on the symptoms, right?
Correct.
Is this a message?
Yes, it is, because many parents, they come completely destroyed by a previous counseling, which have they received a lot of wrong information, and that's what I said before, that the level of anxiety is paradoxically so high compared to the more often benign phenotype of this anomaly. So we say that the minority of patients that need surgery, even if they have symptoms, not all of them need surgery. They need a follow-up, and we need to be really downhearted to follow these patients.
Thank you so much, Marco. Thank you, everybody. It has been a great night, and we've been asked to conclude. And I'd like to thank Simona for helping me with the organization and the choice of topics. I'd like to thank our usually the mentor for every session, Dr. Silverman, and the panelists for beautiful talks. And also would like to thank our audience. Please note that our next group of speakers will be from the UK, and usually the fetal talks are the last Thursday in the last week of the month. Our next speakers will be John Simpson and Dr. Carvalho and Dr. Garlin Shalin. And so also, if you're interested, you can watch the whole session on the YouTube in the Congenital Heart Academy channel. And I think a lot of people are watching right now. And it's a pleasure and honor to see you. And thank you so much. Bye-bye.
Bye.
Thank you. Bye.
Thank you. Bye-bye.